Hello and welcome back to another episode of the AHF podcast. I'm your host, Joe Schwab. There are few surgeons as close to the epicenter of anterior approach hip surgery as Professor Frederic Laude. Practicing in Paris, France, Frederic trained under Émile Letournel, the protege of Robert Judet. Together, Judet and Letournel revolutionized surgery of the hip and pelvis, transforming acetabular fracture care from mostly non-surgical treatment to a full-blown discipline within the world of orthopedic surgical trauma. And while Frederic saw many of these advances in fracture surgery firsthand, he also recognized the benefit of some of Judet and Letournel's, at the time, less well-known developments, like anterior approach hip replacement. I caught up with Frederic a recent weekend morning before he headed off to ski, and our wide-ranging conversation bounced back and forth from how he was exposed to anterior approach at first, how he helped develop an educational system around it, his newfound interest in LinkedIn, and how he's working with a group of like-minded surgeons across Europe to help foster its growth. Let's join in on the conversation.
So, Professor Frederic Laude, welcome to the AHF podcast.
Thank you.
You're located in Paris, France.
Yes.
And I think a lot of anterior approach hip surgeons would agree that France, and Paris specifically, is a special place in the history of the development of the anterior approach. So from your perspective, what are some of the key developments out of Paris that have helped make the anterior approach what it is today?
There is two things that change a little bit the world of anterior approach. First, Joël Matta came a long time ago in Paris and started to do the anterior approach. I think around 97 or 96 or 98. I don't know exactly the time, but he started to do that because he had seen Émile Letournel doing this kind of cases. I think also something that really pushed the anterior approach was the fact that Wimmer promoted the dual incision at the early 2000s. And people rediscovered the anterior approach, and especially when we tell them that it was possible to do everything through the single anterior approach, that people start to get interest again in the anterior approach. And maybe I would say maybe the last, I'm not so sure. I think the fact the Austrians start also to do anterior approach without table was probably something which was quite important for the anterior approach. But it was without the table, so it's another story.
And you have worked quite a bit as in terms of educating for anterior approach, specifically with Medacta. And tell me a little bit about how you developed an educational platform with them regarding anterior approach.
Okay, it's quite funny to see that in the 90s, the anterior approach had nearly disappeared. When I tried to promote this approach, it was like, we are not interested. Even especially American company at this time, they start to get interest when Joel started to show that it was possible in America. And then I think I started to work with Medacta 2004. I had a few surgeons that visit me to see how it works, because early 2000, so 3-4 years before I was working with Medacta, a few surgeons visit me, but it was very unusual. But so we start 2004. And, it's quite a different job to know to do it and to teach it. So at the beginning, people were just coming to see me. They go back home. And that was a disaster because you cannot understand everything in one single shot. Maybe you can see me doing one or two cases, but that's not sufficient. So we decide very fast that was not the solution. The solution was to do some cadaver course, which is still, I think, the gold standard today. And also what they call mentoring. People, at the beginning, I was going to the surgeon who want to start, and I was helping them show how to do. So usually I was doing one case, he was doing 2 or 3 other cases, and I was just behind them. So it started really in Switzerland. And after all over, at the beginning, I was very busy to travel everywhere. But after I was able to teach some guy who become really good, they also teach. So it was like something very positive because many surgeons now, I'm not the only one to teach, I would say. I don't teach anymore the basic. If I do some course, it's more a revision course or advanced course. The guy, but I think it was really a very good and interesting way to do that. And I think education is really the basis of our job. We can put a lot of technology behind whatever you want, but education side by side is the basic for us.
Yeah. It's interesting. I watched an online Q&A that you were a part of. This was maybe about 5-6 years ago. And this question came up about how do you approach learning curve for surgeons who want to learn anterior approach. And you made a really interesting point that seemed to focus on what I would call, you didn't use these words exactly, but you said really the focus should be less on the learning curve and more on the teaching curve, which is how do you become better instructors? How do you become better teachers, as opposed to how many surgeries does it take for a surgeon to be proficient at it? It's how can we adjust our philosophy to make them better surgeons?
Yeah, one thing what's very important for me and very efficient with Medacta, I was teaching the guy, and the guy started, and after I had the news, I had the information, what was the problem? The problem was, by example, to cut the femoral neck. So I insist, I try to find the best way to explain how to cut the femoral neck, how to place the retractors, and each small step, sometimes it's some very small step, and if you miss one of those steps, that's a problem. So really by having a feedback from what was the problem the surgeon encountered, I was able to change the way I was teaching. And that was really interesting for me because I told you I knew to do it, but teaching is another story. And just because I had the feedback of all those cases, the problem there, I would modify the way I was teaching. And that was really important.
So I find this really fascinating. How do you approach those modifications in your own way of teaching? I mean, obviously you see the areas that your learners are struggling. But then what do you do in your process to make sure that you can teach it differently, better, more effectively the next time?
I think when I do my surgery, the idea is I have no parasite movement. I try to do everything step by step, the more logical and simple, as simple as possible. And I think this is a very good way. I just want to come back to in the 90s. I was a resident with the entire approach I learned from Le Tournelle was, he was not teaching anything. He was, show me, and if you can do it, you can do it. But there is another school in Paris, which was Cochin, Marcel Kerboul. They were doing the transcauteric approach, and they were doing exactly like that, step by step, how to do a transcauteric approach, Charney style. Huh? And I must say that was super efficient. So I decided to try to do this way of teaching to the entire approach. And that was so efficient because the way Le Tournelle and everything else teach me was, you just watch me, don't ask any question. If you can do it, you can do it. If you don't do it, I'll do something else.
It's a real sink or swim educational philosophy. So that's interesting. I see you're reasonably active online as well, making comments on sites like LinkedIn, on other people's posts, for example. Is that something you enjoy doing, or is that something you sort of feel a sense of obligation? Like, is that an extension of your teaching, or is there something else?
I'm on LinkedIn for only maybe 2 months. Before I didn't even knew what it was. But honestly, I think it's quite fascinating because what I receive like news from LinkedIn is only on orthopedics. So I see a lot of other guys, makes a great contact. So, and also it's a very good way to promote simple things. And I will try to place one small video or explanation or teaching every week. I don't know how long I can do that, but I will try every week to do one stuff like that. So I show some critical step of the teaching and everything, but I will try. It's brand new for me. Huh? No, I'm not social media guy.
Are you you're enjoying it at least?
I was a bit afraid at the beginning, but I quite enjoy it. The problem, I have many guys who want to visit me now, so I don't know how I can manage that, but I enjoy to do. Yeah, it's quite nice. You really just realize that all the fascination about this approach. So it's interesting. I don't know how many followers I have in 1 or 2 months. It's crazy. Or maybe it's not crazy at all. It's just regular, but my feeling it's crazy.
It's not what you expected, maybe, huh?
No, not really. I was just curious at the beginning. Some guy said me, you should go on LinkedIn. So I went there. I was positively surprised.
Well, that's good. I mean, it's interesting. Not everybody has such a positive reaction to, using social media, but I think that speaks to the community of surgeons who are interested in the anterior approach and their desire for high quality education and high quality materials. So,
I think I was especially fascinated by people from, I will say, third country world, because there is no more third country world, but from India, Turkey, Egypt. Those guys really want to learn. That's fascinating. They just want to improve and learn and become Chinese. I have some visitors from China. They are really, they want to grapple all everything you know.
Yeah.
That's interesting.
Yeah, and oftentimes those are folks who are tackling some of the most difficult cases, diseases and situations that that I would say in France, certainly in the U.S. and Switzerland, we're much less likely to see. It makes the education of that quite interesting, doesn't it?
Yeah, absolutely. Yeah, they have some crazy cases also.
So apart from your activity online, you're on this organizing committee for the European Anterior Hip Meeting, which takes place June 26th and 27th, I think, in London. And this is the first meeting of this organization. And my impression is that this organizing committee is kind of a powerhouse of European anterior approach surgeons, including you, Richard Field, Michael Leunig, Christophe Korten in Belgium, and Jonathan Hutt. Tell me a little bit, how did this meeting come to be, and what are you trying to accomplish with it?
I honestly, I would be totally unable to organize this kind of meeting. I'm really the worst organizer of everything. If you watch my desk where it is, here it looks like nearly okay, but if you go, it's a nightmare. So Richard Field is not like that. Richard Field is a guy who likes to organize everything. So this is really his idea. And as you know, we are very good friends, and I really admire him. And I say, whatever you ask me, I will do it. So I have no choice. So, and we also try to invite Christophe Korten, Michael Leunig, the other guy who really promote this approach and are really very serious guy, very enthusiastic guy. So I think it should be a good, and we also wanted to have something dependent of what happens in America, where it's very active, and Joel Mata is very active, also a very good organizer. So we have the Richard Field, who does the job very well. So I want to thank him for doing that.
And what do you think is the opportunity in Europe in terms of anterior approach? There's a decent amount of anterior approach being done. Of course, it's different country by country. But what are the opportunities in improving anterior approach in Europe that you see?
Yeah, there is some country, by example, like Belgium. Nearly 70 to 80% of the cases are done through anterior approach. In France, I would say it's around maybe 40, 30. Posterior approach is still very strong in France, especially because of dual mobility implant, which is maybe 50% of the market share. Mm-hmm. But by example, in England, it's maybe 1 or 2%. Right. So in England, there is a lot of, probably the Scandinavian country also, and all those countries that really pushing, like Poland or Czechoslovakia. It's really, people are interesting. And also Turkey, Egypt, all those countries also, which is not really Europe, but very close to Europe, they really want to learn. So I think there is a lot of opportunity.
And do you see this committee organizing meetings on an annual basis, on a regular basis, or is this kind of we're going to see what happens?
We're going to see what happens. Usually it's in June, the last week of June. So England is nice at this time, especially Richard Field organized something after, which would be very nice. I love it. So maybe we're going to see. We're going to see. And if it's a success or not. So we're going to see.
I'm interested too, shifting gears just a little bit. In addition to anterior approach, you're known in the field of hip preservation, young adult hip surgery as well.
Yep.
And I want to know how, from your perspective, how is having an understanding of young adult hip disease, how has that shaped your the way you approach total hip replacement, or the way you approach patients about total hip replacement, or the way you do anterior approach?
Yeah, I think it goes in the same way. My idea to have only one incision from child to the end of your life. So, by example, when you do a PAO, it's nearly an anterior incision. When you do now, I do femoral osteotomy through the anterior incision. And when I do my first case, I do through the anterior incision, because this is you can go 3-4 times. I know that without damaging any muscle, and the patient do well. And also, when you see very young patients doing preservation surgery, sometimes it doesn't work so well. So you have to find a solution. But those very young patients don't want to be like an old guy. They want to do sports, they want to do skis, they want to do everything. So it's really nearly the same approach. You have an implant, of course, but at the end, the philosophy is the same. You want to give them back their normal life, not a life that would be a guy who is 75 years old, who have arthritis at the end of his life. So that is, for me, it's a complete continuum. And I like to do that.
Yeah.
I have some patients, I have done some 25 years ago preservation surgery, and they come back to have the total hip replacement. It's logical. I think it works.
And if they come back to you, it means they must have been satisfied with what you did.
Yeah. They say, when do you retire? I say, a few more years.
Well, so so this raises a question. I know there's lots of people who want to come visit you. You have been very thoughtful about the way you approach education. What's the plan in terms of what would you want your legacy to be? What would you want to be known for? What would you want to be remembered for as you now have transitioned to sort of the senior statesman of hip surgery?
I'm a little bit afraid that nobody will remember you in 20 or me in 20 years. So I don't know. Usually people forget. But maybe, I don't know, to do it in a very nice way. And also probably, I'm very proud to do revision through the approach, because if you know to do it, it's really fascinating for the patient.
Yeah.
And what else? Okay. We'll see.
You'll see.
Not so sure.
Well, I actually think, Frederic, this has been just a fantastic conversation. Your time is precious, and I want to make sure that I'm not taking too much of it. But from my perspective, one of the most fascinating perspectives that I've heard on education, and I really appreciate what you've been doing for all the surgeons around the world. I know there's many in the U.S. who have come to visit you and bring your level of enthusiasm for anterior approach back to the U.S. There's many where I'm located here in Switzerland that have also come to visit you. So on behalf of them, thank you for the work you're doing educating everybody.
So you are in Switzerland. You know the guy?
I can't see it. My screen's a little small.
Yeah.
Who are we looking at?
Yeah. It's this guy, really, Andre Geister. He was from Basel.
Uh-huh.
He really helps me to promote, because at the beginning, when you're alone to promote something, it's a little bit not very efficient.
Yeah.
So this guy really helped me to promote. He's from Switzerland, Basel. He died a few years ago.
Uh-huh.
He was a very nice surgeon. And he really, when you have a few guys that follow you and help you that's really interesting, because when you're alone, it's not very efficient. For a long time, I was alone to try to promote anterior approach. Didn't work very well. Medacta really helped me.
Yeah.
And this kind of guy really also helped me. And so I was to thank the Swiss surgeon to have followed me at the beginning. That's interesting. And after all the world, now we have to convince the English guy.
English.
That's another story.
Many thanks to Frederic Laude for joining me on the AHF podcast. And thank you for listening to this episode. I hope you enjoyed this conversation as much as I did. If you can remember to take a moment to like and subscribe, you would be helping us find more people just like you to share our thoughts with. You can always drop an idea for a topic or any feedback you like in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. New episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy and healthy.